All right. Good afternoon, everyone. Today we're going to talk about cardiac masses, CMR assessment by cardiac masses. I am Karla El-Tallawi, one of the multimodality imaging specialists here. We're not gonna be talking about echo today, unfortunately, but we're gonna mention some of the echo pearls and we're gonna show some of the echo images and how we investigate those, and then when we properly order an MRI. So to begin with, how do we assess what is the differential whenever we usually start on echo and we see a cardiac mass, right? So whenever you see a cardiac mass, it's usually one of 5 things. So either an artifact, it's either not an artifact, it's real, but it is a normal variant, or it could be a thrombus, it could be a vegetation, or it could be a tumor. These are the options. And obviously within each, there are a few other differentials. Okay, so first, a couple of words about the advantages, disadvantages of echo and MRI. Obviously, echo is readily available. You can, see the mass, the location, its morphology. You can even have the advantage of the Doppler, seeing if there's any damage on the structure because of that mass. And then based on that, you can put a differential diagnosis, right? So most of the time, actually, the vast majority, you can see a mass on echo, and you have an idea. This is a thrombus. This is a myxoma, maybe. This is a vegetation. Most of the time, you don't need actually further imaging. However, disadvantages and why we need sometimes further images is that because it is operator dependent, so sometimes you don't have as good of images, right? Image quality. You don't have soft tissue characterization like we have on MRI. And obviously, if you need to go even further, you will need a TE, and TE is a semi-invasive modality, so not everybody will be fit for that modality. On the other hand, MRI is good for the accurate assessment of the anatomy, morphology, size, the extension of the mass, because it has a wide field of view. So we can see the extension of the valve, the mass, the vascularity of it, and the tissue content. The added value is that we can see its relationship to other cardiac or extracardiac structures. We can plan therapy, right? So we can do serial imaging because of its consistency and monitor the response, and identify the differential diagnosis based on all this information. The disadvantages is in terms of, obviously there are inherent MRI disadvantages pertaining to claustrophobia and having metals and kidney disease, but also you have to know in terms of masses, if you have small, rapidly moving or randomly moving masses, they're not good fit for MRI. Don't order MRI for those. Like, filamentous vegetation, even like going outside of masses, let's say you have flail mitral valve, you have this cord moving, you won't see it on MRI. So MRI is more like a long exposure imaging modality. So like anything that has random motion, it's not gonna average in the final image, right? So be aware of that. How do we do the MRI? There are 2 main sections. There's the anatomic assessment. Obviously, we do the axial, coronal, sagittal views. And then we have the cine imaging, which you are all familiar with. After we're done with this anatomic assessment, we have the tissue characterization part. And this is also divided into pre-contrast and post-contrast. Within the pre-contrast, we can do T1 weighing, T2 weighing, fat saturation, and T2 star in order to identify whether there's fat, there's fluid kind of based mass, there's more iron based. And then when we do the contrast part, also that can be assessed in terms of the first pass perfusion, is the mass vascular or not? The late gadolinium enhancement, did it retain the contrast? And then finally, we have something called long inversion type imaging, and this is specific for thrombus, because thrombus is a very important, obviously, clinical finding that it has its own imaging strategies and pearls, because it will affect, most of the time, it will affect the management. We'll talk about this strategy with some examples. So first, starting with the anatomic assessment, obviously we have the standard cardiac imaging planes, like the 4-chamber, 3-chamber, 2-chamber, but we have also the option and the ability to do targeted non-standard imaging based on the mass that we have. So this is an advantage of MRI here. So we can tell the mass, the location, the size, the mobility, the physiological impact, the invasion, extension, all of that. So you can tell here, for example, this weird looking mass on short axis, it looks like another aortic valve here. But if you look on this view here, you can see how it's extended down from the SVC into the RV inflow and how it's showing this way on the short axis. So based on MRI, you can get this 3D information about the mass and its extension. And obviously, we'll talk later about This is pre-contrast, obviously. We'll talk about the contrast to try to figure out what kind of mass is, such an example. So next is with the tissue characterization. As we said, this is divided into pre-contrast, post-contrast. Even without contrast, you can get an idea, right? You have T1 weight sequences that will identify mostly fat, but even acute thrombus, it will highlight if you're suspecting thrombus based on other features. You have the T2 weight sequences more for water-based structures. And then you have the T2 star. And then second half of this protocol is the contrast-enhanced images, where, as we said, we have the first pass perfusion to assess vascularity. Vascularity means it's a tumor most of the time, or vast majority of the time. And then we have the delayed hyperenhancement, fibrosis, necrosis. And then, again, the long inversion time imaging to detect the thrombus, as you can see in this image over here. So what is the mass assessment approach? So it's always good to have kind of an algorithm as to how do we assess the masses. So this is step one. We see a cardiac mass, usually on echo, right? The question is it a true mass or is it a pseudo-mass? Is what we are seeing really something biological there, or is it something else, right? So we need to first rule out a pseudo-mass. And we know on echo that we have a lot of structures that can behave like a mass, and those drive a lot of the MRI indications. Most of the time, they are in the atrium, right? Whenever you see something in the ventricle that's weird, it's probably real. But whenever you see something in the right atrium that's weird, a lot of times it's not. It could be a crista terminalis, a eustachian valve, lipomatous hypertrophy, Chiari network, you name it. You all know these, usually these structures, right? So this is the first step. We need to rule out this part. Let's make this a little bit interactive. Mass versus pseudomass. So this is the echo. I'm sure you've seen a lot this thing over here to different extent of sizes when you're reading echoes. What do you think? Mass or pseudomass? Pseudomass. What is it most likely? Crista terminalis, right? So you can see now on the MRI, on this particular slice, how it kind of fits to the contour of the IVC over here. So the crista terminalis is this fold in the right atrium where the SVC and the continuum of the SVC and the IVC inside the right atrium. So you can see here how it kind of fits, you can draw a circle here of the cross section of the vein, right? All right, so this is a 73-year-old female with epigastric pain. Anything unusual? It could be a trick, it could be just nothing. Where? What? It could be normal again. What? Where? This thing, right? What is this? What could it be? What is the differential? Hiatal hernia is one, and obviously you need to also always think of the descending aorta, right? If you have a descending aortic aneurysm, it can look similar. Like if it has a thrombus, it has complicated thrombus, it can look similar. Right, so in this case, the patient got an MRI, and you can see also the hiatal hernia here, right? So this is the first step one of the algorithm done. Let's say we ruled out a pseudomass. Now we know it's a mass. Now the question, is it a tumor or is it a pseudo-tumor, right? So we know it's a mass. Now the next question is it an abnormal, expected finding kind of acting like a tumor, or is it a real tumor? Within the pseudo-tumor, it could be fat, it could be fluid-based, it could be calcium, or it could be a thrombus. Again, thrombus, we'll hear a lot about thrombus in this talk because it is a very common and clinically important finding. So now let's try to look at the pseudo-tumor aspect. Let's look at this one here. Tumor versus pseudo-tumor. What do you see? Yes, lipomatous hypertrophy of the intra-aortic. You frequently see it on echo, but again, these come in a spectrum. Sometimes when it's so severe or so prominent, I should say, because they are prominent, they trigger, red flags in the echo that, this could be something else. Let's get more imaging. And on the MRI, you see here, for example, very nicely the dumbbell, and obviously this is a prominent lipomatous hypertrophy of the intra-atrial septum. On the T1, you see how it is high signal, similar to the pericardial fat here. And when we do T2 with fat saturation, we saturate the fat, we remove the signal from the fat, it becomes black. So this is confirmation that this is a lipomatous hypertrophy of the A side note, I'm going to go on a tangent here. I always mention this in the echo lab. You see when you see this on echo, this is the lipomatous hypertrophy, right? This is not inside the cavity, right? This is not interacting with the blood cells. This is, if you look at this pathology specimen here, this is fat that is invading the interatrial septum and splitting the left atrial side and the right atrial side of the wall of the interatrial septum and situated in between, right? It is not within the cavity. So that's important for you to kind of know and understand. Tumor versus pseudo-tumor. This is easy. First of all, the location. It is located at the right cardiophrenic angle, right? At the angle of the heart with the diaphragm on the right side. Most commonly, if you see, even on echo or chest X-ray or whatever, a rounded, well-circumscribed structure there, it is a pericardial cyst, right? So you see here on cine, which is more T2 weight, has high signal. On T1, it has low signal. On T2, which is fluid, it has high signal, and then it doesn't uptake any contrast with, on LG. So this is a pericardial cyst. Let's see who's gonna figure out this one. 77-year-old asymptomatic female, surgical removal of an LA mass found on TTE. Not showing the TTE for a reason. What do you think? Is it a tumor or a pseudo-tumor? Is this how you see a mitral annular calcification? Is it? I've never seen such a mitral annular calcification. Can you go one step further? Yes. So this patient got an MRI, right? Look at the MRI. T1, no signal. T2, no signal. First pass perfusion, no perfusion. On LGE, you have inside no signal, but there's always this rim around it. There's usually this fibrotic shell around caseous necrosis. So this is what you expect to see. And the patient got a CT calcium score. Very high calcium score, as you can see. Okay, so this is caseating mitral annular calcification, right? So this is also something that you don't see every day. But probably on the echo, you would have suspected it, right? Because you see this like high signal area coming, but obviously it was unusual that triggered further imaging. Okay, tumor versus pseudo-tumor. Or you can go even further. That's what I'm saying. I know you know what this is. It's a thrombus, right? A lot of times you just don't need much to figure it out. That's what I'm saying. On echo even, you can have a very high likelihood of knowing what it is just based on the location, the history, everything put together, right? So you see these two floating masses in the right atrium, someone with AFib. On the T1 and T2, there is slightly higher signal. This is expected sometimes in usually acute thrombi that can have a high water content. And then on the first pass perfusion, it's dark. Obviously, the contrast does not go in. And then this is the long inversion time imaging. So this is we saturate, we invert the proton, and then we wait for usually 600 milliseconds. Usually at this mark is when protons located inside the thrombus will have a zero signal, right? So this will guide us that and confirm for us that this is truly a thrombus. What about this one? Pattern recognition. I know you know what that is, right? So this is Loeffler, right? Loeffler endocarditis, and you can see usually what's situating in the apex is a fibrothrombotic material, right? So you can see the thrombus here, like there's no LG, and then you have this rim of fibrotic material around it, right? Okay, so how does MRI diagnose thrombus? Again, thrombus is very important. We're talking about masses, but we have to highlight always thrombus. So there have been studies looking at MRI and different features that we see, and then what is the value or the weight of each in terms of the accuracy as detecting confirmed thrombi. And obviously, for example, having a small size favored thrombus versus a mass, right? Smaller size. So the bigger the structure is, if it's usually, let's say, more than 2.4 centimeter in this study, it becomes less likely being a thrombus. It becomes more like of a tumor, right? So, but out of all these, including first pass perfusion, LGE, and T2 and everything, this inversion time of zero signal at 600 milliseconds had the highest accuracy of 95%. So obviously we always put things together, but this is the one that usually seals the deal for this particular diagnosis. So when we compare echo to MRI, when it comes to thrombus, where echo lacks is sensitivity, right? Because if you see something, if you see a black structure in the LV apex that is akinetic, this is highly specific for a thrombus, right? But sometimes you can have a layered thrombus somewhere on an akinetic segment, whether it's the apex or the inferior wall, that you will miss on echo. So this is where it lacks in the sensitivity. So, but MRI is both specific and sensitive, right? So how does echo improve? Is by giving contrast. So when we give contrast, sensitivity almost doubles on echo. It goes from 33% to 61%, at least in this study. But the remaining part that becomes lacking compared to MRI is the field of view and the visualization. So even if you give contrast, even if you have a small apical thrombus, if the TAC did not sweep the apex, right, you might miss it. It could be located on the apical inferior wall that was not covered by that echo plane. So it's very important for the TACs, whenever the indication is stroke or LV thrombus or whatever that is, and you give contrast, to always sweep the apex, right? Another reason why it could be missed, as we mentioned, is the mural. So specifically in this study, small thrombi and mural or layered thrombi are the ones that were missed by echo. And this is understandable, right? It would be located against the wall. You won't see any weird protrusion, right, that will trigger something. So this is usually the advantage of MRI over echo. But again, I think on echo we can always improve our acquisitions to increase the sensitivity and the specificity. Okay, so now we move to tumors, right? So now we ruled out a pseudo-tumor. Now we're thinking that this is a tumor, right? So usually the hallmark of a tumor is contrast uptake, whether in first pass perfusion or LGE, right? So if there is first pass perfusion, if there is LGE, it means there are vessels. The contrast did get there somehow. And when it gets there, it means this is most likely a tumor. So I know Victor covered this probably during the last professor rounds, but the most common of the cardiac masses are the secondary, are the metastasis, right? Usually direct extension, lymphatic extension, hematogenous extension from the breasts, lung, melanoma, right? And then within the primary, the most common are the benign, right? You all know that myxoma, papillary fibroelastoma, lipomas, and then within malignant, the vast majority are angiosarcomas, right? We're gonna show in the next slides how do we differentiate the primary and the, whether it's metastatic or malignant or benign. So this is just I thought this was like a nice visualization that will narrow the differential. Even you can use it for echo in terms of based on the location, what to think about, right? So if you see something on the valve, it's vegetation usually or fibroelastoma, right? If you see something in the left atrium, thrombus, myxoma. I'm gonna just name the top here. Right atrium, angiosarcoma, lymphoma, metastasis, right? Because they go through the venous side. Pericardium, also metastasis can spread to the pericardium or invade the pericardium, or a pericardial cyst. And then within the ventricular walls, usually we have fibromas and rhabdomyomas. Lipomas, hemangiomas, metastasis also, like they can cover any chamber. But this is a kind of nice, I think, visualization. This is a review from here by Dr. Kasi, kind of separating nicely in a schematic way how to differentiate a kind of a malignant versus a benign tumor. So malignant tumors are usually larger. It all makes sense, what you will see here. They're usually larger, usually more than 5 centimeters. They're usually invasive. So you will see invasion of the pericardium, a pericardial effusion, pleural effusion, invasion into the wall of the ventricles, for example. They have increased first pass perfusion, meaning increased vascularity, also a hallmark of being malignant. And because of that, they have increased late gadolinium enhancement. Okay, and as you mentioned, they have pericardial effusion. Benign tumors, they have probably all of that, but to a lesser extent. So they are smaller. They're usually well circumscribed. They don't have this like irregular morphology. They have no or very minimal first pass perfusion, and they have also no or very minimal late gadolinium enhancement, and they usually are not associated with a pericardial infusion because they're not invasive. This is such an example of a malignant tumor. You can see how it's invading the left ventricular wall. There's a pericardial effusion, and then you can already see this like signal, high signal within it, which is a sign of probably vascularity there, right? There's fluid there. T1 and T2 shows, again, high signal, meaning that there is edema. And then on the first pass perfusion also, the muscle, the mass does perfuse, and this one ended up being a cardiac metastasis. This is a case actually from last week. I showed it to some of you in the lab. Let's see if someone will be able to figure this one out based on what we talked about so far. Not the MRI fellows. So as you can see, on the cine imaging, as we said initially, we have the anatomic imaging. So we have a mass situated inside the ventricle, right? It is more or less well circumscribed. It doesn't seem to be invading, right? It doesn't seem that you don't see a pericardial effusion. You don't see, invasion of the muscle, right? And then this is a T1 map or T1 image. What do you see here? High signal, low signal from the T1. Low signal, right? No, high signal. Nobody's saying anything. Right? So there's a high signal on T1, right? What does that mean? This patient happened to be big, so you can see all the fat in the anterior chest wall, right? And we know that T1 is more, you get high signal from fat, right? So this tells you that this is a fatty mass, essentially, right? And then we did a T2 sequence with fat saturation. So look at the anterior chest wall, no more signal there. And then suddenly the mass disappeared, right? So what do you think that is? Lipoma, right? Fat, yes, but more specifically lipoma. Also, yes, that's a good observation. So it is usually lipomas. They have a stalk to the wall of the ventricle where they grow out of. In this particular case, it was attached here to the inferior wall. Unfortunately, I had to make the images smaller. But actually, it goes inside the ventricle, and then it grew and encasing the papillary muscles, right? I wouldn't call it necessarily invasion, but like just by virtue of proximity, it grew there. So yes, it was. And then again, for the MRI fellows, if you look just on the cine imaging, you see this dark border around it, right? So that by itself should give you a signal that this is fat, right? Because this is a cancellation artifact. You see how the mass is traced in a black line around it, right? This is not biological. This is not. It doesn't have like a particular border, or this is just an MRI kind of artifact of whenever they have border between fluid and fat, you have this cancellation of signal there, creating this black rim around it. So this is, again, a sign, just based on the cine image, that this is a fatty mass. Again, no or very minimal first pass perfusion, and also the LGE was very minimal. This is, again, a review from here by Dr. Shah. I'm not going to go over all of this, but this is something that we use in the lab whenever we see a mass. We kind of look at the T1 signal, T2 signal, post-contrast, and then to kind of put things together. Location is obviously, it's not here, but it's very important. The shape, the morphology, as we said. So in summary, clinical history, signs and symptoms, biochemical and tumor markers, and the results of all cardiovascular imaging are put together in order to figure out what the mass is. And then sometimes you don't, and you need a biopsy or excision. So this is just an outline of, based on the patient's characteristics maybe, or what we need besides figuring out the mass, what kind of modality to choose. So if you need coronary confirmation, you can get a CT sometimes. If the mass is CT will give you something for the mass. If the patient is claustrophobic, CT. If you have contraindication, metal. If you have, as we mentioned, small, highly mobile structure, MRI is not recommended. Usually TEE has the better spatial and temporal resolution for that. But most of the time, actually, MRI is the one that's gonna seal the deal. Thank you very much, and happy to take any questions. Again, it's 12:30, so I was on time because it was supposed to be an echo and MRI. Any questions for Dr. Shah? Yeah, for the echo text here, I think it's very important by echo to, whenever you see a mass, go out of the box, get extra images, unusual angles. If you have a stroke, you give contrast, sweep the apex. And a lot of times, I think for us, we need to have the habit as echo readers, whenever we see something on echo, so instead of just mention it and then go to the next test, just ask the tech to go get extra images. You can save, more testing. If crista terminalis, for example, you can figure it out with some extra testing, extra images.
So, Carlos, let me ask you. You showed some, stuff on thrombus, right? How MRI is more sensitive for thrombus than echo.
Yep.
And it's important to make a distinction. It's not so much as MRI itself, it's the contrast MRI. If you look at cine MRI,
Yeah.
it does a little bit better than echo to get better visualization.
Yeah.
It doesn't pick up all of these,
Yes.
especially the neural parameters as well.
Yes.
So the
Yes.
idea is really, it's that giving contrast and looking at differential tissue contrast, that's the key thing.
Yeah.
I think. To be able to identify, especially these mural thrombus, which can be layered against the wall. So it's really hard to differentiate what's wall versus the fact that there's a thrombus in there.
I agree. Yeah.
That's
Yeah.
important.
Yeah. So contrast MRI versus contrast echo, it's still MRI is better, and as we mentioned, it's mostly because of the field of view, because of detecting those layered thrombi or the thrombi that were not captured on the plane of the echo. All right. Thank you.